Although we're first thing in the morning, we are running a bit late already, unfortunately, and this is a really busy session whereby we're going to be looking at some research trial updates. We've got a number of speakers, and I think the order, we're not going to introduce the speakers one by one. We're just going to let them go as the speakers come up. So if you are a speaker, please make sure you're up near the front. You know where you are, and I'm hoping the order is sorted because we haven't got an order here, okay? So please take your seats, ladies and gentlemen. We're going with 5 minutes, aren't we?
Yeah, absolutely. The only thing is Kathy Price has to be at 9:25.
9:25, Kathy Price.
She's phoning in.
Okay, I hope they know that.
They do.
Yeah, okay, good.
It's all sorted.
So you
Patrick.
haven't got time. Patrick. And speakers will stand up at 5 minutes, okay, to give you a signal.
Go to the slides, please.
So this is Mr. Statham. He's presenting on behalf of DENS for Paul Brennan. Hopefully slides came through.
I do have some slides. I hope they're going to appear.
It's the DENS trial.
We good? Okay, that's fine, yeah, the DENS trial.
Statham, halfway down.
Halfway down.
That one.
That one, yeah.
That's it.
Bingo. Smooth as ice.
They're coming up. That's great. So thanks very much. I'm sorry many of the audience has left, but to the rest of you, thanks for staying. I'm going to talk briefly about the DENS trial, a handy acronym because it's the duration of external neck stabilization following odontoid fractures in both older patients and in frail adults. It's been supported by the NIHR to the tune of £1.8 million. And the rationale of the project was that there's an increasing incidence of odontoid fractures, particularly in the elderly, following low-impact falls. And there's a general feeling amongst spinal surgeons, 90% of them feel that the use of a collar is hardly worthwhile. It doesn't improve radiological outcomes, and on the other hand, it can be quite difficult for elderly patients with the collars rubbing on the skin, sometimes affecting swallowing, sometimes affecting breathing, and generally being a nuisance with patients not actually complying with collar treatment when it's been offered to them. So many clinicians have thought using a collar has become rather worthless, but they're rather afraid to dispose of it because they think something disastrous might happen. So this trial was to look at whether or not in this group of elderly patients with an odontoid fracture or frail patients, whether it's better to abandon a collar and not use a collar at all, a hard collar at all, and see what the outcome is. And it's assessed at 12 weeks using a standard Euroqual 5D5L summary. And the trial protocol is quite straightforward. A suspected fracture, patient can have a collar put on while they undergo investigations, such as the CT scan, and if they meet the inclusion criteria, which are named there, then they can be potentially randomized to either have a collar or no collar. And the inclusion criteria are about age and frailty. They have to have, obviously, an odontoid fracture. And then the question is there equipoise? And so a local spinal consultant has to decide that there's equipoise in that particular patient. And the injury has to be relatively recent. So patients with complex fractures, with other conditions that you'd worry about a lot, such as ankylosing spondylitis, DISH, high-impact injuries, for instance, or patients that can't tolerate a collar, you wouldn't include. Once they're randomized, they either abandon a collar or they stay in the collar for 12 weeks. And they have 2-week, 6-week, and 12-week follow-up by the local research team. And at 12 weeks, those who had a collar have the collar removed. There's then a 6-month follow-up, and in the trial protocol there was a 12-month follow-up, but that, for practical reasons, has now been stopped. We originally wanted 25 sites. We've been able to involve 28 sites, and we're hoping for over 800 patients in the trial over about 30 months. We've so far recruited 85, and we'd like to have 165 by August. We've amended the protocol to try and enable this to happen, and so because of practical considerations, we've included in the group of no collar the use of a soft collar, because we know a soft collar is of no use to people in terms of stability and outcome, but it can be of use to patients in the first few days if they've got neck pain. So we've allowed soft collars to be used initially in the treatment group that have no collar. We've removed the 12-month follow-up because that was becoming a practical difficulty, and we've simplified patient data collection with a patient diary, which is a means of trying to find out whether they're using the collar at all. We've had a good response from many centres, particularly Leeds. Over the last few months since November, they've been recruiting one a month. Some have had practical difficulties in recruiting, but I'd like to encourage you all to try and push this forward, to try and get recruitment up to speed so that we can answer this clinically important question on behalf of the team that's been studying this. Thanks very much indeed.
Thank you, Patrick. We're going to move on and not do questions at the moment because we're going to run out of time otherwise, but I'm sure presenters will happily give you more information as their teams will if you want to grab hold of them or go via their study websites. So hopefully we should have Kathy Price phoning in from Southampton virtually via Zoom.
This session's certainly making the tech team earn their salary first thing on a Thursday morning.
Okay, so Kathy's not joined us for the moment, so if we can go to Ashley Cole, please. And this is the BASIS study.
Thanks very much. The Bracing Adolescent Idiopathic Scoliosis study is a comparison of nighttime against full-time bracing in adolescent idiopathic scoliosis, and is another NIHR-funded trial. We have to recruit 780 patients with adolescent idiopathic scoliosis and randomise them equally to nighttime brace or the current standard of care full-time brace. It's a non-inferiority trial, and the primary outcome for success is the patient reaching skeletal maturity before the curve progresses to 50 degrees, and failure, the curve progressing to 50 degrees before skeletal maturity. Secondary outcomes are quality of life and cost effectiveness, and the study completes hopefully in 2031 when I'll retire. Central team, lots of thanks. Lizzie was on the previous slide, along with the website, which was designed by Morph. There's more people in the central team, of course, Kerry and Heather. Thanks to my co-apps, many of whom are in the room, Adrian, Sashin, Laura and Sarah. Martin Wilby sits on the trial steering committee, Phil Sell on the data monitoring and ethics committee, and thank you very much to all the PIs, fellows and specialist nurses who are recruiting patients. Currently we've got 21 sites open, and to put that into context, there's one further site in setup, and that leaves only 2 non-recruiting paediatric spinal deformity sites in the UK. 19 of our sites have recruited at least 1 patient, and we've got a total of 143 patients as of yesterday. Thank you, Belfast, who've recruited to our target of 780. So we're at about 18% at the moment. We've just been past our internal pilot at the end of February, and although options are under discussion, a recent meeting with NIHR has been very positive. We've completed our qualitative study. 25 parents and 20 patients have been interviewed about their experience of BASIS and also their experience of bracing. We're developing an action plan based on this, both for lessons learned for recruiting to BASIS and also the expected problem of information and patient support, which will hopefully be actioned by SORC, the patient help group. This is our recruitment at the moment. Not great to start with, but the line is starting to become parallel with our blue line, which was our anticipated recruitment at the start. Here's the sites. These are in order of the date that they opened. You'll see St George's at the bottom, opened 2 days ago. Haven't recruited anybody yet, but then it's only 2 days. So over the whole study, we've been going for 19 months, which is a total of 210 recruiting months across the whole site. So with 143 participants recruited, we're recruiting at a rate of about 0.7 patients per centre per month. We're going to need to extend our recruitment out to May 2026, and the key number that we need is 17 patients per month from our 21 sites. The learning points to improve recruitment, we need sites to see these adolescent idiopathic scoliosis patients as quickly as possible as new patients so that they don't miss the window for bracing. We need, ideally, for you to make sure that all the consultants in your centre are recruiting patients and screening patients for this study and referring those patients through to the PI. Ask your orthotists to flag to the PI any potential missed recruits. We've had one of those in our centre. And use the associate PI scheme. This study is registered for the associate PI scheme, so your trainees, your specialist nurses, your extended scope physiotherapists and your orthotists can all be part of the study. And remember, there's a fee paid per patient, which you should be able to access through your R&D department. The PI fee is just short of £400 per patient, and the research specialist nurse fee is getting on towards £200 a patient.
Need to wrap up shortly, Ashley. Thank you.
Next steps, reproducibility study for our radiographic adjudication committee and BASIS 2, which I'll tell you about later. Quick plug for another study just approved by NIHR, which is pain relief after instrumented spinal surgery. 3-arm trial, erector spinae block, intrathecal morphine, unusual care, normal analgesia. Quite a big study, and email me if you want to be part of it. Thank you.
Okay, can we go to Chevron Steins, please?
Morning, everyone. This is slightly different. It's a prospective cohort study. This is funded as an NIHR portfolio study funded through my NIHR fellowship. I also work clinically as an advanced physio practitioner in spinal interface service. And we know our guidelines recommend we consider epidural steroid injections for severe sciatica, but if we're honest with ourselves and our patients, there's no clear evidence as to why some patients improve and why some don't. So that's the premise for the study. So can we predict from how patients present to us their likely improvement following this intervention? And by ESI, I mean any type of therapeutic steroid injection for sciatica radicular leg pain. So the predictors that I'm collecting in the study are based on the literature and consensus work, so self-report characteristics, some items from clinical assessment and MRI variables. The outcome is leg pain intensity at 6 weeks after the injection, and also doing 3-month and 6-month follow-up, and you can see the secondary outcomes there. So once a patient consents to take part in the observational study, they get weekly text messages until those time points, as well as questionnaires. So how's it going? My statistician, Professor Richard Riley, said I needed 351 with 6-week follow-up to develop a prognostic model where I could include 25 factors. I thought that would take 18 months. So we're 15 months in, and so far open in 15 sites, 437 patients invited, and 200 of those have agreed to take part. So a bit to go yet. And of those, obviously, some are still waiting to have the injection. So I've asked NIHR for a 6-month extension to recruitment. Everything's up and running, but it'd just be a shame not to get the time to recruit. Trying to do a light touch approach to recruitment, so asking clinicians to ask patients they see to introduce the study and just gain their consent for Keele CTU to contact them. And the conversion rate of patients who agree to be contacted is variable across sites. So the blue arrow just shows, the blue bar shows a site, how many patients they're inviting, and the orange is the conversion rate. The average is about 47%, but there is variation. And some sites have struggled to engage for various reasons. So yeah, at best month, about 8 of the 15 sites are engaged. So it's been a very much kind of keep adding new sites to get the numbers. The challenges along the way, what has really sort of baffled and frustrated me is the long R&D process. I found the ethics actually was quite straightforward, but it seems to go into the void once you send it off to hospitals R&D. And the average wait time has been about 5 months to actually open the study. Obviously, once studies are up and running, it's keeping them engaged, getting that balance between nagging and encouragement. Obviously, things have changed between when sites say yes, we can get you patients, and the very flux NHS situation at the moment, having to shift to more of a screening of waiting lists for patients waiting for injections, as opposed to that inviting them at that face-to-face or follow-up consultation because of the long waiting lists. Things I'm trying to do to improve recruitment. Ashley has just mentioned the NIHR Associate PI scheme, so POISE is part of that as well, and definitely those clinicians who do it are more engaged, and you do see an improvement in recruitment. I do open drop-in meetings for study sites. We send weekly update emails. Hopefully they can see how they're performing against other sites, and the CRN have also been involved. So anyone here involved in the POISE study, please continue to recruit, or if you know anyone involved, pass on the word. I'm not looking to, unless you've a super efficient R&D department who could open the site within about 6 weeks, I'm not really looking to open new sites at the moment, just hopefully maximising what we've got going. Thank you.
Thanks very much.
Alex. Alex Guben? Is Alex?
So on behalf of the trainee studies.
Thank you. Don't know which one.
What's your...
It's the CLIP study, please.
Say it a little bit louder.
What's your name, please?
CLIP, Priyanka.
Priyanka. So that one,
Priyanka.
Thank you.
Thank you.
Thank you.
So good morning. I'm here to present on behalf of the BAS Trainee Committee. We've got an ongoing project, which is the CLIP, which stands for the CSF League Incidents and Plan Project. This is a trainee collaborative. It's the prospective multi-centre national study, which is ongoing. The premise of the study was we looked at how CSF leaks are dealt with, and we found no consensus in the current practice. We therefore thought to look at what is being done, and therefore the aim of the CLIP study was set to understand what the current practice is, both intraoperative as well as post-operative, which includes the management as well as investigations. The methods we've included, as I previously mentioned, it's a prospective study, multi-centered study, and it's a trainee collaborative. It was set to start in January of 2023, and it did start then. We've got about over 40 centers registered for this. We will look to collect data for 6 months, so the study would end in June of 2023. The data points that we are collecting is to look at, they've all been mentioned at the bottom, but the bits that we're concentrating on is to see the type of study, the grade of the surgeon, the amount or the extent of the dural tear, and what we are doing for these patients, both intra-op as well as post-op management. Where are we now? This is what I've mentioned. We've launched in January of 23. We've got over 40 centers registered. And where do we go from here? We hope to finish collection of our data in July of 23, analyze it, and have all of the data ready with aims to present it at the upcoming BAS in 2024, and hopefully have it published by then. Thank you.
Thank you very much. Samira Sedum? Samira here? No?
Samira, what are your slides named as?
Discuss trial. If you select ASIF, ASIF 915. Right, good morning everyone. I'm not Dr. Sedun, but I'm presenting on behalf of Samira Sedun and Marius Papadopoulos from the academic unit at Atkinson Morley in Tooting. Update on the DISCUS trial investigating the role of duroplasty in cervical spinal cord injury. And the premise is that after cervical cord injury, the cord swells and compresses not only against the bone but also the dura. And with raised interspinal pressure, there is a concomitant reduction in spinal cord perfusion pressure. So the thought process is by not only doing a bony decompression but also an expansion duroplasty, there's an improvement in cord perfusion pressure and subsequent reduction in secondary injury and improvement in outcome. So the inclusion criteria are any adults with a cord injury from C2 to T1, Asia A to C after resuscitation and exclusion of spinal shock. A surgeon needs to deem a posterior approach as part of the decompression appropriate and needs to be operated on within 72 hours. The patient also needs to be able to consent with or without a proxy. We're excluding patients with dural tears or any major comorbidities, those with concomitant thoracic or lumbar fractures which could confound neurology and other CNS diseases. So there are two arms to the study. The control arm is surgery and laminectomy, comparing surgery, laminectomy, and duroplasty. There's an optional mechanistic component to the study where centers that have capabilities to do so insert subdural intraspinal pressure monitors as well as microdialysis catheters to assess metabolomics and spinal cord perfusion pressures in the two groups. But the primary outcome is looking for a change in the Asia motor score at 6 months compared to the admission. We're also looking at objective and subjective secondary outcomes at 6 months, looking at walking, upper limb, hand function, grip strength, quality of life indicators, and a post-operative MRI scan. So we've opened 15 of 16 major trauma centres in the UK, Edinburgh being the most recent yesterday. Stoke, watch out, we're coming for you. We've also recruited the following spinal cord injury rehabilitation centres. So after these patients undergo their surgery, they're sent over to these rehab units and their 6-month follow-up is completed there. Doing okay from a recruitment point of view. Certainly at St George's, recruiting at about 1 patient every 30 to 40 days. And to drum up our recruitment, we're also opening centres across Europe. I certainly don't have a overpriced mug to offer you like Ben has, but if you recruit 5 patients, you're welcome to come down and visit us in Tooting. We can treat you to a curry and some beer.
Right, the IT team, we understand that Kathy Price is now ready to join on Zoom. I'm hoping via the magic of Nafis texting me and me speaking to Kathy from here. I'm hoping Kathy can join us now.
Thank you very much. Can you hear me?
Price, halfway down.
Kathy Price.
Can you hear me? Can you hear me now?
Slides 2 down from where you are now.
Kathy.
Hi,
You're
can you
live.
hear me? Can't hear me.
You're live, Kathy. We can see you and hear you.
Oh, fantastic. Brilliant. That's great.
Oh, actually, I lied. We now can't hear you.
Yeah. Oh, okay. God, this is...
At the moment, we can't hear you or see your slides. Maybe you would need to share your screen.
I'm just going to...
Directly might be my hunch. And possibly unmute, he says, hopefully. Well, it wouldn't be a meeting if we didn't have a few technical difficulties, eh? Everything's gone so well so far.
Can you hear me
Apologies,
now?
audience.
Because I can't do anything different. I'm unmuted.
I think maybe we'll try and come back to you, Kathy. We'll come back to you in a minute.
Okay, in that case, Ben.
I'm going to have to go.
tech team. We'll go back to live here with Ben. What are your slides named as?
Davies.
Davies.
Third from the top.
Right at the top there, thank you.
Oh no, that's that's all. Yeah.
Is that the right one? Okay.
Brilliant. Yeah. So 2.5 trials from us. Recede myelopathy is a regenerative medicine trial. We're just about to get off the ground. Polyfix DCM with a sub-study called Distressed, all through the NHR. And acknowledge a massive team putting this together, which for brevity I'm not going to go through. Disease we're familiar with. We've been very fortunate to talk about it throughout the conference. Recede myelopathy is essentially the first regenerative medicine trial. We've repurposed a drug from Japan called Abudilast, which essentially mechanistically from Mark's lab we think works by inhibiting phosphodiesterase pathways and shifting the cell into the spinal cord into repair paradigm, which we hope can regenerate, improve recovery, treat pain. The trial has been very difficult to get off the ground for many reasons, but is now ready to go beyond Cambridge. We've done an internal pilot, but essentially it's anyone who is moderate to severe myelopathy, offered surgery as an adjuvant to surgical treatment, randomized, double-blind, placebo, etc., etc. It's a drug trial. It's got a lot of monitoring. Obviously, it's a repurposed drug, new indication. It is quite cumbersome, and I think it's incredibly promising, and we're really keen to get many centres involved, but you do need to have the right support in your centre to participate, because this is not something to be done by a couple of clinicians, I can assure you. Polyfix DCM is more conducive to a couple of clinicians, although wider support is always helpful. Polyfix DCM is trying to test the hypothesis that motion restriction with surgery for myelopathy is advantageous, particularly for posterior decompression. So this is multi-lever posterior decompression. Do you fix or not? It's laminectomy, therefore laminectomy with fusion. And essentially, there's a big mismatch around the world in terms of how we practice. Some believe that the fusion offers much to gain, preserves alignment, treats neck pain, prevents a sort of further spinal cord injury. Others believe it simply adds complexity, cost, and morbidity to the patient, and that's what we're trying to get to the bottom of. We tried, when we set this up, to look at subgroups. There's some very key criteria how we include patients, but when we looked at it with the early investigators, you can see 7 different real-life cases, 16 different surgeons. No one was agreeing on how to manage these patients. So ultimately, it's very pragmatic, it's open. If you decide you want to operate posteriorly and you have equipoise, you can randomise. It's obviously a subset of practice. It's therefore a big population we need, and it's something that will need a lot of buy-in, which we're working very hard to get in order to answer both inside the UK and out. We're therefore expecting sites only to probably contribute 4 to 8 patients per year, so it's a drip-by-drip progress. And so far we've been really won over by the support we've been seeing, so we can just about see that we are hitting the recruitment curve that was predicted to the NHR as we end the pilot phase, which hopefully means that they're going to fund the rest of the study. I'll just signpost Distressed, which ultimately is setting up in 5 existing centres. It's a sub-study inside Polyfix we just had funded. And it recognises that I think the biggest challenge for interpreting the findings of Polyfix is going to be the challenge of whether we've had a selection bias, whether we've missed subgroups, etc., etc. And so this is trying to get to the mechanistic basis of how fusion might help the spinal cord. Does it really do that? And if it doesn't, does it ever? And I briefly mentioned this in the last talk, but this builds on a sort of pipeline of technology we've been trying to build in Cambridge, where essentially you take the MRI, the FlexX X-rays, and you integrate them into a model which starts to show you how and where the spinal cord is being injured. And from that, can we establish, is fusion reducing that? And ultimately, perhaps if not, the subgroups where it might be benefiting. And we're combining that with some advanced imaging and serum biomarkers. But ultimately, we need a lot of people to contribute, and not just to help contribute, to help share the findings. So if you're interested, please drop me an email, and I'll upgrade my offer of the mug to a curry and a whatever St George's can offer you. Thank you.
I think you'll have to go for champagne, Ben, to beat the beer in Tooting. We're going to try... IT team, we'd like to try Kathy Price again, if that's possible, in the hope that maybe no price.
Okay, Sachin then, please. So second one down, please.
Yeah, so I'm going to present about forensic. I think we spoke about it yesterday for some of you who were there. So this is a clinical and cost effectiveness for lumbar fusion compared to best conservative care for patients with persistent severe lower back pain. The full team is labeled there. Some of them are here in the audience. Thank you. And thanks to most of our membership who contributed to putting the PICO together. So the main objective is superiority of lumbar fusion versus best conservative care, and to investigate the cost effectiveness of lumbar fusion surgery. These are the outcome measures that we'll be using, ODI being the top one to look at the clinical effectiveness, and then the rest along with that. It's a multi-center 2-arm trial with one-to-one randomization with 135 patients in each arm. And the inclusion criteria being patients who've got back pain between the age group of 18 and 65 with back pain for more than 6 months, who have been through the core therapies program, where they have MRI changes of degeneration or enough there to suggest that that could be possibly the cause of the back pain. If you do suspect CT, that is welcome. Patients who've had previous discectomy and the pain is predominant in the low back, they should have had their core therapies first before they actually are eligible for the study, and then they get randomized, and they're usually for only 1 or 2 levels, no more than that. Exclusion would be any patient who needs any neurological decompression, so anybody with leg pain, claudication is not included in the trial. Patients who needs fusion surgery for other conditions like deformity, infection, tumors, high-grade slips, pain anywhere else and everywhere else is excluded. The patients who've had previous fusion surgery or orange flags. So, as I said, prior to enrollment in the study, all these patients would have gone through the back pain pathway where they would have had their core therapy before they get enter the study and randomized. So the randomization, the fusion surgery would be any approach you prefer, but the strong feeling from the CAG, the clinical advisory group, was we should exclude BMP. Best conservative care, now this is a little bit of a hot potato, but our physio colleagues have been working on this to decide how we package this, because these patients would have had all the treatment, so you would select what's worked well for them and you enhance what has that after this patient has been assessed and seen by a senior physiotherapist. So where are we? We've been successful with the application and we're waiting for the approval. So hopefully once we're ready, we'll be knocking on everybody's doors, because we want everybody involved in this, please. Thank you.
So Adrian's going to finish the session. I think despite our best attempts, we're not going to sadly manage to have Kathy online.
So, yeah, next one, that's it. Thank you. So that was the... okay. So thank you. I'm going to finish off just to say that I think this session shows that as a spinal societies and area in the country, we really are hitting with our research. So thank you, and please continue. My study was a call that the HTA put out for the pharmacological management of back pain and sciatica, because the NICE guidelines of 2016 took most of the medication away, which is also what led to the Sessions trial, because they also took the surgery away. And this has come to a funded trial that we've called MEDAL, Medications in Acute Low Back Pain. The aims being to find out which analgesic ladder is most effective in acute low back pain with somatic ill-defined leg pain, or true neuropathic sciatic type pain with the back pain, looking to see what best improves function, allows people to sleep better, gets you back to work, reduces depression, anxiety, and resolves your symptoms. And the solution is a platform trial of the 3 clinical scenarios, randomising to 1 of 6 escalating analgesic ladders, daily outcome measures via electronic devices for pain and recovery from pain, and the ability to escalate up your analgesic ladder every 72 hours at a minimum. The main outcome measure really is to say, how do you feel you've got better? Because it's very easy to use a primary outcome that is a population basis, but everybody feels pain differently. So it really is saying, are you better than you were on your individual basis? And we're scoring that daily up to 8 weeks. And we're collecting all the usual secondary outcomes as well. We have an embedded health economic and qualitative research study, and it's a primary care study. We're looking at 120 sites. We need 4,000 recruits. It's Bayesian analysis, and at this point everyone puts their head in their hands and shakes because nobody really understands how that works, and I'm not the person to explain that. But we're looking to start recruiting in August 2023. It may well be in a site near you. Thank you very much.
Thank you very much. Can I, speakers, we do have just 5 minutes, and can I just ask anyone really, there's a theme here around recruitment, and I was just thinking if current plans are the triumph of optimism over experience, or whether something's going wrong with feasibility studies. It seems lots of people are really struggling and having to extend with their recruitment. So I was just wondering, as a general question to the trialists in the room, and just thinking about those 4,000 that you're going to be targeting, you know, what are people's reflections on strategies for recruitment and the variance between presumably feasibility work and real life? Anyone fancy taking that one on? Apart from Ben, who's excluded because Ben was the only presentation that seemed to be on track.
Well, I can certainly say that my impression is that the NIHR are very keen to drive efficiency and recruitment, and I'm not sure that there's always that mix of discussion about what you can achieve and what they'd like you to achieve. And I'm not sure that's necessarily joined up.
Yeah. I think the main reason is that we all guess at what we're going to recruit. You know, you've got to put your finger in the air and think, roughly how many of these patients do we see, and ask a few friends as how many they see, and there really isn't anything more scientific than that for most studies.
Okay. Patrick? I'm just interested, I mean, I've kind of dipped my toes into the feasibility study literature and just thinking about that phase. It seems these particular trials are so expensive and difficult and sophisticated to manage. This seems like a key issue.
I think it's difficult for many reasons. I remember a cervical arthroplasty trial in which we estimated that we'd have a certain number of patients, and there was an inclusion criteria where the BMI had to be less than 30. That excluded every Scottish patient. I mean, it didn't need to be 30, it could have been 35. It didn't make, so it's very easy to inadvertently exclude people. And then there's the sort of the hassle factor. Nobody's rewarded directly, nor should they be, for including patients in the trial. It's just extra work. So you have to be enthusiastic and maintain your enthusiasm, and that's the only solution, really. Yeah. And so tribute to Ben, because he is, and he has, but the rest of us are failing, slightly, anyway.
Well, I mean, that's a really good insight into the role of performance science for a PI. There's a question, is there?
Just an idea, and this is, I'm not sure if this will work, but it's probably looking at it the wrong way round or the other way round. Have we thought about contacting patient groups so that they request of their surgeon for certain trials like yours, Prof. Gardner, or yours, Prof. Ahuja, when it comes to things like back pain? That's what they do in certain cancer therapies. So people go and ask their physician, and then those people can then join your studies, as in PIs, and bring a whole new set of people in. That's the way that this will probably be driven, through the press, through the public, for big questions like back pain, which we don't have answers for.
And I would agree, and I think that comes back to Ben's pictures earlier about you've got a product, but how do you package that and how do you advertise that? And perhaps that's what we're not so good at, is getting the message out to those that could benefit from it.
it's very different asking someone in a clinic room, do you want to be part of this trial? And a patient coming to you and saying, I've heard that this might help, please can I take part? I'm willing to do any one of these 6 arms or 6 treatment things. And then the clinicians in that unit can say, actually, we'll join this medal trial and bring in another 50 patients.
Well, on that positive point, we'll end the session. I thank you very much for your patience with the tech. Thank you very much for those who are doing this hard work, which is clearly performance art as well as academic practice. Thank you very much, everybody.